And I'll go ahead and introduce our next speaker, Dr. Marni Falk, who's the Executive Director of the Mitochondrial Medicine Frontier Program at Children's and Professor of Pediatrics at the University of Pennsylvania. She will be speaking today. Her topic is Advancing Understanding and Therapeutics for Leigh Syndrome Spectrum Disorder. So with that, I'll turn it over to you, Dr. Falk.
Okay, great. Can you see my screen?
Yes.
And it's a PowerPoint, and I'm enlarging it. Let me make sure you can see that. Can you see that?
That's perfect. Thank you so much.
Okay, wonderful. Okay, well, good morning. Thank you so much for having me. It's such a true pleasure to be here in World Mitochondrial Disease Awareness Week. I'm Marni Falk, and I'm going to be talking about advancing understanding and therapies for Leigh syndrome spectrum disorder. I'll focus on 4 areas, a little ambitious, but I'll give overviews on gene curation, prospective natural history study, preclinical models, and precision therapy trials, all for Leigh syndrome. This is my disclosures. I am a co-founder of a company working to develop therapies for rare disease, scientific advisory board member, research collaborator, consultant, and PI on multiple programs trying to, again, develop advanced understanding and therapies for mitochondrial disease. First, I'd like to begin with an update on gene curation activities for primary mitochondrial disease with a focus on Leigh syndrome. Many of you may know, back in 2020, I edited a book with about a dozen esteemed colleagues trying to create a unified source for trainees and doctors and families, really understanding from a genetic perspective what's causing mitochondrial disease. We're now working on the 2nd edition. And the goal is to understand how each gene was discovered and its inheritance patterns, the age affected, the clinical features, the therapies, the support groups. And this version contains more than 250 different genes, and there's more than another 150 being added to the 2nd edition. That intersects with this resource for the mitochondrial disease community, the mitochondrial disease sequence data resource. We started this in 2012 and it went live in 2014 as a website with my esteemed colleagues, Dr. Guy and Dr. Shen. And here the goal is to create a unified resource for all the research and clinical community describing all the genes and variants and clinical features. And there's actually a registry and lots of tools and information here, a virtual registry of all cases that have been published in the literature. For example, with Leigh syndrome, that you can come down here and browse. And on top of all of the published evidence, we wanted to create curated evidence in line with what the global genomics community is doing to understand which genes really do and don't cause different diseases. 10 years ago, it was found that a lot of the published genes for all sorts of different diseases weren't the correct answer for individual patients, maybe because people didn't look at a broad enough swath of what could be happening, or because people had more than one thing going on. And so it's really important that the community come together and agree which genes cause which diseases and which variants in those are actually disease causing or not. And so this is based upon public literature reviews to create different categories of evidence to understand what's known about whether a gene or a variant of that gene can cause disease. And so we created the mitochondrial disease ClinGen gene and variant expert panels with more than 50 colleagues around the world who get together and evaluate on a very regular basis with NIH funding support whether or not any gene causes a mitochondrial disease or whether a variant in that gene. And there's a lot of different criteria that have to been described for whether how strong, high or low, their evidence is that a gene causes the disease. For example, the common mutation in the cystic fibrosis gene clearly is a pathogenic variant for which there's a lot of evidence, it's very high, and it's a gene for which it's very high. So this gene has a high likelihood, and the variant has a high likelihood of being causal of cystic fibrosis. But there could be variants, even though the gene is well known, that maybe themselves are not causal. There could be variants in genes that really we don't know much about. And if the gene has no evidence for causing a disease, then it doesn't really matter what the variants in them are. So this is the sort of thinking and categorization that the community works on. So back in 2017, my esteemed genetic counselor colleagues shown here and colleagues around the world, together with Dr. Guy, Dr. Zokoly Cunningham, Dr. Rahman, Dr. Wallace, we all got together and started to look at what genes cause Leigh syndrome spectrum disorder. And we looked at some of the curating the evidence for the variants and some of the more common genes. This work was completed. I'll show you a summary in a moment. And we went on and got second tier funding to curate not just genes that cause Leigh syndrome, but most of which are mitochondrial diseases, but also any form of primary mitochondrial disease, and that's ongoing at the moment. We published last year in Annals of Neurology 113 genes that have been curated by the expert panel with community consensus based upon these criteria for what Leigh syndrome is. So a neuropathologic diagnosis or neuroimaging findings, and at least one of the following of regression, delay, or psychiatric manifestations, with further support by a range of other laboratory findings. And so this was very important to come up with this consensus first list for the evidence. And there, again, the expert panel members are from all over the world, clinicians, researchers, laboratory directors, and it's been an incredible community to come to consensus, because it's very important to know which genes cause mitochondrial disease, for example, before you can decide if a given patient with a given gene disorder is or isn't a candidate for a given clinical trial. This has all been published just to show that the wide breadth of evidence from limited to moderate to definite for whether any Leigh syndrome association is present with a given gene. And we worked on nuclear genes and mitochondrial DNA genes. For the nuclear genes, we worked on all sorts of different inheritance patterns. And we worked on like, where was the evidence coming from, from mouse studies, from Drosophila studies, from zebrafish or yeast studies, and how much evidence was there based upon when the gene had been first reported in the literature or discovered. We've gone on to look at 141 additional nuclear genes, 65% of which, for example, are definitively associated with mitochondrial disease. And we've also gone on to look at all 37 mitochondrial DNA genes, where you can see, again, limited to moderate or definitive evidence based upon genetic or experimental information in the literature on all the mitochondrial DNA genes. So this has been a big community effort that's really critical to guide our understanding collectively of the genetic landscape. What's also equally important is that when you come up with any therapy for mitochondrial disease or for Leigh syndrome, you need to know, well, how would you study that in a person and show that it actually makes them better or that it changes compared to their natural history. So for example, Leigh syndrome can often have peaks and valleys. How do you know you're not just getting somebody, at a certain course of their disease and they would have gotten better anyway? And so this is what the regulatory agencies want to know, is what normally happens in these different conditions. So working with the International Mitochondrial Disease Patient Groups, I highlighted on the last screen. This has been a multi-year effort to first design and now conduct a natural history study of outcomes so we can understand what's normally happening over time in patients around the world with Leigh syndrome. And then that can be used as the basis for intervention to show how that might be improved compared to this natural history baseline in patients. And a whole bunch of different types of medical information, objective clinician-reported outcome measures of the disease burden, dystonia, movement, and balance problems, and then observer-reported outcomes of fatigue, quality of life, caregiver burden, and function. This is an example of a current slice of who's in the study. So sites were capped at 30 subjects each at the moment. And this is the sites that are enrolling in the United States and in Australia. And so, which is just coming on. And you can see again that we have up to 27 months of data. These are the genes present in the patients that have been enrolled into the study. And you can see among the mitochondrial DNA, the most common cause of Leigh syndrome is ATP6. In the nuclear gene category, the most common cause is SIRF1, followed by PDH1, and then some of the complex 1 genes. The age of enrollment, the age of genetic diagnosis, the years living with Leigh syndrome, these are all things that we're learning about. And you can see the gender balance as well. This is an example of the symptoms present in the subjects enrolled into the study to date, with global delay, dystonia, hypotonia, weakness, dysarthria, dysphagia as the top problems. We've also asked the most bothersome symptom, and here you can see in this word diagram, communication, mobility, dystonia, balance, seizures, weakness, fatigue, and so on. We're also very interested in infections, since it appears that Leigh syndrome patients are susceptible to decompensation with infection. And so we're working to understand how different types of infections might present in different parts of the year. We also have been looking at some of the outcome measures to understand among the different gene categories, for example, who's mild or moderate or severe, and can we categorize genes or etiologies in that way. There's a whole lot more coming. That's just a snapshot of the data. The next step that I'd like to share in this brief overview of all that's going on for Leigh syndrome is how do we bring therapies to patients? There aren't really big multi-center clinical trials in Leigh syndrome patients. So does that mean we have to wait years, or can we think about a precision therapy approach where we get therapies to patients earlier? And that's what we've embraced here at the Children's Hospital of Philadelphia, is really working to expand our precision therapy offerings to get patients first therapies as early as we possibly can for treatment purposes or for early clinical research understanding about what to carry forward and what to leave and switch to something that might have more promise. So we think about expanded access programs, single patient INDs with the FDA, either emergent or non-emergent, open label extension trials, off-label therapies, and new agents, actually. And the goal of all this is to do precision monitoring, not just to give it to somebody and come back in a year and ask what they thought, but to do very objective assessments on every single patient to know if something is working or not working, and to work very efficiently and expediently within our regulatory environment and the research infrastructure to understand and learn what are the most promising therapies that we need to get back to children and adults living today with mitochondrial disease and Leigh syndrome. So this is an ongoing collaboration with patients, expert physicians, and sponsors. And we've begun to see some successful treatment outcomes and positive patient experiences. This is just a high-level overview of some of the precision therapy trials that are either now live or actively underway, either with pharma sponsors or really just internally with investigator-initiated studies. The ones in yellow are those that will apply to individuals with Leigh syndrome. The ones in underlined have come out of research in our own research group suggesting that there's evidence in rigorous preclinical model evaluations for bringing these forward. So these include L-imipritide, dichloroacetate for PDHC deficiency, probucol for primary mitochondrial diseases, a form of IV CoQ10 for primary CoQ10 deficiency, a new form of cysteamine, a prodrug in Leigh syndrome, epicatechin in mitochondrial myopathy, rapamycin or sirolimus in Leigh syndrome spectrum disorder, which we hope to launch very shortly, as well as high-dose thiamine in individuals with single large-scale mitochondrial deletion disorders. So we're very excited, and you can reach out to me or to our research team. Sarah Nguyen, for example, is the main point person, and if you have more information. The next thing I want to share with you is about preclinical Leigh syndrome models. So we think about a lot of different models. We're not attached to any single one. We actually think about moving across them to gain as much evidence as possible for safety and efficacy. I was speaking with somebody from the FDA just recently, where many other disease areas are looking for signs of toxicity in preclinical models and lack of harm, which is still important in mitochondrial disease. But because we understand that there's so many causes and there may be so many different mechanisms, we'd like to also see some evidence of efficacy, that we improve survival, function, or feeling in these models that we can take forward and we can prioritize our candidates. So we think about all sorts of different candidate therapies, things that are empirically suggested, have been used without evidence, drug libraries, genetic libraries, novel compounds with partners. And then we try to take it forward to each patient for patient-important outcomes, as I mentioned before. The concept is therapeutic cross-training. We've patented this and published on this to explain that we can do things rigorously before we get to the actual patients to understand, so again, lifespan, survival, development, growth, movement, different aspects of mitochondrial function and cellular physiology. And we can do this pretty fast now. Over time, we were doing them one at a time, and we started to notice that our worm, that is a model of complex 1 disease, a recessive NDUFS2 complex 1 subunit called GAS1, is short-lived. But we can improve its lifespan with antioxidants, with metabolic modifiers, and with signaling modifiers. And actually, they act synergistically, meaning that when you combine them, you get better effect than any one alone. And so we've started to transition, as you saw before, some of these therapies to patients. The other concept is that you don't necessarily have to fix the mitochondria to improve the health of an individual living with mitochondrial disease. It would be ideal to fix wherever the causal problem is, whether it's genetic or a function in the mitochondria. But the cell has a lot of sophisticated adaptations that over time are actually contributing to the problem. And if we can modify these adaptations, we can improve the health of the cell. So I won't go through all of these, but a lot of these are signaling modifiers and pathway modifiers, and frankly, nutrition that does a whole lot to correct some of the signals coming out of the mitochondria and adaptations that are themselves contributing to the problem. Oops. And ultimately, we'd love to have a test to say, this is the right combination of therapies for you. And we've started to move very quickly. So rather than doing things one at a time, we have robotic systems. We have automated screening systems. And we've been able to optimize screening in C. elegans, for example, of a range of different types of causes of Leigh syndrome and other mitochondrial diseases. So that fact that we can now screen an entire FDA library in 1 to 2 weeks and start to see which ones lower mitochondrial stress. We've also begun to create zebrafish models, more than a dozen of them, due to sophisticated partnerships and opportunities to apply very advanced genetic technologies in a matter of weeks to create, using CRISPR technology, genetic mutations, knockouts and knock-ins of patient mutations, so that we don't have to guess if they're causal. We can see what's wrong, and we can really start to have something to test all these therapeutic ideas in. And so I've shown here the map of, basic cellular metabolism involving the mitochondria. We have mutations affecting pyruvate dehydrogenase, complex 1, complex 4, complex 5, the translation system, and so on. And it's very rewarding because in order to move a field forward, you have to have models to test. You have to have evidence of something being either harmful or potentially helpful. And we've done this now many times over, and we're really focused on understanding, what therapies can we move forward, and where can we understand where better therapies might come once we understand why one therapy, for example, doesn't work. So I'll end there and thank everybody for the time. We also do, of course, bring things to cells, I guess I should say. So we go from screening C. elegans to screening zebrafish to screening, invertebrate to vertebrate to human cells, looking at from all the way from how an animal swims or survives or moves down to how the mitochondria are formed and cells interact. So there's so much we can do now that we never really had the potential to do before as a community. And that's why there's so much hope that we could look at each cause of mitochondrial disease, each cause of Leigh syndrome, common subsets of Leigh syndrome, find unique therapies and common therapies that we can bring forward to patients, and that we have committed people who understand the disease, who have outcome measures that we can quantify, and that we can really move the most promising and the safest candidates to patients as quickly as possible. I, of course, want to thank the whole village of people here at CHOP and beyond, in the laboratory, on the clinical research team, in the clinic, the administrative side, the diverse funding from the federal government, the United Mitochondrial Disease Foundation, the CureOurs Foundations, multiple other family foundations and donors, the CHOP Research Institute, and all of our colleagues that together, I think give us a fighting chance to really make therapies a reality. So thank you.
Thank you so much, Dr. Falk. We'll